So you guys did asthma with Talwar, right? Did asthma? You didn't do asthma yet?
No, we did.
You did?
We did.
You okay?
Like.
You all right? So asthma, how do we diagnose asthma? Chest X-ray? Is that diagnostic?
No.
No, we don't need any films whatsoever to diagnose asthma. Pulmonary function testing, right? History. So all these things diagnose asthma. And then one day you get your patients that come into the emergency room complaining of asthma exacerbation, shortness of breath, coughing, difficulty breathing, wheezing, and you shoot a chest X-ray on them, and they have hyaluronopathy. They have reticular opacities. So this hyaluronopathy, all of a sudden our eyes light up, and we start thinking the worst. What are we thinking when we hear mediastinal hyaluronopathy? We start thinking of malignancy, right? Like lymphomas. So younger patients typically don't have primary lung CA, but hyaluronopathy in a younger patient, we start thinking lymphomas, right? Usually starts off in the chest, spreads to the neck, and then goes diffuse. So we can mimic that. So that hyaluronopathy is one of the key findings. Reticular opacities are a key finding. And then you have other findings. Again, it's a diffuse disease. It very commonly doesn't just stay to the lung, although lung is primary. That is most effective. But again, eyes, joints, adrenal glands, nervous system, cardiac tissue, anything else can be affected. Soft tissue, skin issues. So all these things can be par for the course with that. So it is not that uncommon. You will tend to stumble across this. All right, 60 per 100,000. You don't have to memorize that. It's just so that you can get an idea. So 2.2 per 100,000 in Taiwan versus 160 per 100,000 in Sweden. So is there a genetic component to this? And they feel that absolutely there is. Much higher in African American than it is in Caucasian. Can it be familial, where you have clusters of this in a family? Absolutely. So we don't really know what causes it, possibly genetically linked. But again, more common in African American than Caucasian. Does that mean Caucasians aren't going to get it? Absolutely not. Absolutely not. But it's in our age group right here, our age group, that 10 to 40 years of age. That's when all of a sudden we find it. And you may have been misdiagnosed with asthma or just allergic reactive airway disease until you start looking into it. Because chest X-rays don't diagnose asthma or reactive airway. So we wouldn't really think to look into this any further. So again, in this second bullet, that hyaluronopathy, reticular opacities, we just stumble across it on chest X-ray. Is it diagnostic? Are any chest X-ray diagnostic? No, chest X-rays are not diagnostic, ever. Chest X-rays are not diagnostic. They can support your diagnosis, but you shouldn't use them to say, all right, you have a lung lesion that is adenocarcinoma. Can you tell that from a chest X-ray? You have a pleural effusion that is an exudative pleural effusion. Can you tell it from a chest? You can't. So it's not diagnostic. Can you tell it from a CT scan? It's not diagnostic either. So what's diagnostic? Is PET scan diagnostic? No, it's only a scan. It's only a scan. It's not diagnostic. What's diagnostic? Biopsies, pathology, right? That's diagnostic. Those are diagnostic. They lead you, those films lead you to the way of making a diagnosis, but they're not diagnostic. So again, most commonly, it's going to involve the lungs. So wheezing, shortness of breath, coughing, sputum production, dyspnea, may have chest pain. All that looks just like asthma. Right? So it very commonly can look like that. It can look just like reactive airway disease. And again, extrapulmonary symptoms with asthma. Do you get extrapulmonary symptoms? Yeah, you get atopic dermatitis. But do you get erythema nodosum? Do you get cardiac involvement? Do you get adrenal gland involvement? Do you get nervous system involvement? Do you get uveitis, retinal involvement? No, you don't get that with asthma. You could have this right now and not even know. So this spectrum of this disease is very, very wide. We have patients that go around and they're fine. Maybe they wheeze a little bit if they come into contact with certain smells or dust, and they wheeze and they cough, and then they settle down after a couple days. Would you think to do chest x-rays and all this other studies on these patients? No. It's really not indicated. Really not indicated. Fatigue, malaise, weight loss. Maybe you get that. Maybe you don't. That's all systemic symptoms, right? So you don't have to have those issues in order to have sarcoidosis. Lofgren syndrome. All right, so this is when you have erythema nodosum or bilateral ankle inflammation associated with sarcoid. 10 to 15% of your patients are going to have that, roughly. So not that common. Uveal parotid fever, uveitis with parotid gland enlargement associated with sarcoid. Very, very uncommon to see this. So again, this is just pointing out that it's not only just limited to the lung. A lot of times we have other involvement of other tissues. Lupus perineo disease. So sarcoid associated with this villaceous type erythematous lesions on your face. But predominantly 90% of your patients, lung involvement. That third to last bullet, need to know that. All right, that's the classic chest x-ray, the bilateral hyaluronopathy. And what does it mean? It means absolutely nothing. It means that we need to look into this further. It means that we should form a differential diagnosis, and that sarcoid should be in that differential, along with other inflammatory disease states, along with infection, along with malignancy. It has to be evaluated. We can't just say, oh yeah, the person's got hyaluronopathy, have a nice day. You could have just missed lymphoma in somebody. Can you have pleural effusions? Anything can cause effusions, right? But this would cause a cloudy effusion. It would not be a transudative effusion. So everything that we do gets staged in medicine, right? So we have stage 1, which is very, very mild disease. You see my pointer up here? So here, you're going to see a patient that has hyaluronopathy. So this is big, and I like to use the word chunky, lymph nodes. Where after treatment, they're almost translucent and almost gone on the left. On the right, I'm sorry. So that's stage 1. Not that big of a deal. Stage 2, all of a sudden now, we have this hyaluronopathy, but we also have reticular opacities. This is atelectasis right here. Stage 3, now our opacities, it looks much more fuzzy, this chest x-ray, right? But we don't see the enlarged hilum like we did here in stage 2. So your hilum is very enlarged here, but it's not that enlarged yet. But look at these opacities. Look how fluffy white. It almost looks like it's out of focus. So larger reticular opacities are seen. Stage 4, we start getting volume loss now. So if you look at this x-ray, look how much volume we have in these lungs, right? Greater than 10 ribs on a chest x-ray. Nice lung volume here. Look at the lung volume here. So you have 1, 2, 3, 4, 5, 6, 7 ribs on this x-ray. You want 10 ribs on an expiratory film. So we have volume loss here now. So it almost is starting to present like a restrictive disease. So we have volume loss with hyaluronopathy, with reticular opacities in the upper lung zones. So progressive disease. And then, of course, we have nodular sarcoid. When we see x-rays like this, the first thing that we say is, oh my God, this person's got metastatic disease, right? If you can't see this, then we need to have a talk about what you're going to do in the future. So all of these huge, and we call them cannonball lesions because they look like cannonballs, right? Big, huge lesions. And the first thing, again, that I would think of as well is this guy's got metastatic lung. So it can absolutely fool you. But this is why films don't make a diagnosis. So obviously, chest X-ray is okay. CT scanning is much better, but still not diagnostic. Can absolutely give you more of a clear picture of what's going on, but still not diagnostic. So we see all of these issues. End stage, we start getting fibrosis. Hilar and mediastinal adenopathy, though, traction bronchiectasis, cysts, ground glass opacification. So GGO, we call it, ground glass opacities. These are pain in the neck. I'll be very honest with you, because we may never find a reason. You could have had COVID pneumonia and ground glass opacities. It could have been residual from a disease. It could be inflammatory. It could be prior pneumonia. It could be scarring. It could be pre-malignant. We monitor it, it gets worse. Now it's malignant. It could be anything. So they're a pain in the neck. So you know what usually I end up doing when I do a CAT scan on somebody that has GGO? Repeat it in 6 months. Repeat it in 6 months. If it's getting a little bit smaller, good. Repeat it again in 6 months. It's getting worse, then we look into it further. So extrapulmonary. So again, very important slide. That second indented bullet, eyes are not uncommon to be affected with sarcoid. Uveitis can be seen. Nervous system abnormalities can be seen. Cardiac sarcoid is not that common, although I have patients with it. The youngest person, and most people will live a very, very good life with sarcoid. They'll live a very, very long life. They're not going to have issues typically with it. But the youngest patient I ever had that died from sarcoid was 35 that had cardiac sarcoid. All right. And it was just a very, very sad case, 3 young children, and she passed away with cardiac sarcoid. I have a patient now with that's 78 and is going through this workup and has an abnormality on her cardiac muscle on echo, and she's got cardiac sarcoid, but it's only a small area. She's 78 already, so she's had this for 40 years. Again, exocrine, heart, kidney, central nervous system. Women more likely to have ocular and neurological abnormalities. Men, and this can happen to anybody. It really shouldn't be designated as men and women, but hypercalcemia, all right, is one of the things that we typically look for. And about 30% of your patients can end up with extrapulmonary disease. So lab-wise, there is not too much that's specific for this. Obviously, we look for the elevated calcium levels. We look for elevated calcium in the urine. Eosinophils, non-specific, but again, see with allergic disease, respiratory diseases. So we could see eosinophilia, hypergammaglobulinemia. So we could see abnormal spikes in your serum protein electrophoresis, elevated gamma spikes, which can be significant for inflammatory disease. Bless you. The thing that I want you to see here, though, is that this last bullet, ACE levels, serum ACE levels that tend to be elevated at about 75% of your patients with sarcoid. Now, do we do serum ACE levels on just anybody walking around? No. Is it diagnostic? It's not. It's not diagnostic. But is it part of your workup? So you may think about doing this if you see it on CT scan, you see it on chest X-ray, get a serum ACE level. So now you have two things: serum ACE levels elevated, abnormal CT scan, looks more like sarcoid, but we need pathology just to make sure that there is nothing else that we're missing. So you can get that serum ACE level. It's just a simple blood test. So again, definitive diagnosis really doesn't exist, except for the fact that we could do bronchoscopies, CT guided needle biopsies, or mediastinoscopies and sample their lymph node. That is really the best way. Any biopsy procedure to show non-caseating granulomatous disease is diagnostic. So when you get that, now all of a sudden you can kind of sit back and say, all right, it's not malignancy. Now let's treat you. So right now, the mainstay of treatment for sarcoidosis, and it has been for decades, is steroid therapy. So glucocorticoids. So typically, if you have a patient that has first-time diagnosis of sarcoid, they're inflamed, they're having restrictive patterns on their pulmonary function testing, they're short of breath, they're wheezing, they're symptomatic, we'll put you on steroid therapy over a long, prolonged amount of time, taper you down, and monitor you, and a lot of times that will put you into remission. There are studies, and we have patients that do very, very well with inhaled corticosteroids also. But later stage disease, I would not utilize inhaled corticosteroids. They may do very, very well, though, being maintained on it. So medications like Advir, so dual combination therapy, a long-acting beta agonist with an ICS, or Symbicort, or anything like that. And mild disease tends to do very, very well. There is a small percentage of patients, less than 10%, that are going to be resistant to this. And those patients typically have a worse prognosis, obviously. We do escalate the type of treatment that they get to help put them into remission. So methotrexate tends to be one of the treatments that's commonly used. Unfortunately, a lot of mycophenolate can also be used. Interestingly, about mycophenolate, it can actually cause pulmonary fibrosis. So mycophenolate can also be used, but also TNF drugs like Humira, Remicade, things like that have been shown to be very promising in these patients that are resistant to inhaled corticosteroids and oral corticosteroids to help put them into remission. So thankfully, that's only a very small percentage of patients that need this treatment. Prognosis. Most of your patients, I would say 95% of your patients are going to do great. They're going to do great. You're going to treat them. You're going to end up maintaining them on inhalers. They're going to do fine. They're not going to want to follow up for follow-up of repeat imaging because they feel great. Very, very small percentage will have complications. But thank God it's only a small percentage. So I will tell you, 26 years, I've only had one major complication in 26 years of doing this. And that, again, that was a 35-year-old with severe cardiac sarcoid. No, she's gonna get a heart. Say again? You can be put on the transplant list. It just, by the time you're put on the transplant list for cardiac disease, it typically is pretty bad. Any questions with sarcoid? Okay. So non-caseating granulomatous disease affects any age, usually anywhere from, you're young to 10 to 15 years of age up to 40, 45. May look like asthma. You may live with this for a long time before it's incidentally diagnosed. Steroid therapy, inhaled steroid therapy, any patients usually do very well. What's the test that we could do? The serum test? What's diagnostic? Biopsy. Biopsy is the only way we can make the diagnosis. Chest X-ray and CT scan are not. Even the ACE level is not. Any questions with that? Go ahead.
What's the life expectancy of someone with sarcoid if it is well maintained?
They're gonna live longer than me.
What?
They do very, very well. They typically, like I said, they'll die of something else. If they have mild sarcoid, very well maintained, and they're not on chronic prednisone therapy, they do very, very well. It's not even a thought that they have it.
Do certain ages exhibit like more like symptom different symptoms, or does it vary?
So I see patients that have worsening disease, not mild disease, usually in their 30s. Is typically when I'll see that they struggle with their sarcoid. So if they have sarcoid and they have moderate to severe sarcoid, they usually have an issue with it in their 30s. It's usually not the younger, and it's usually not the older. Any other questions?
Is it kind of like
understood as like an autoimmune thing, even though we don't really know.
So we're not really sure. They think it can be. That's why there's a lot of genetic clustering in this sometimes.
And like prednisone, Humira helped.
So prednisone is great as an anti-inflammatory. So, but the Humira part, the TNF drug is great as a immunosuppressive for autoimmune disease. So there is that theory. Same thing with methotrexate. Any other questions with it? But also asthma can be hereditary. So again, it's like, was it really asthma that your father had, or did they have something different? CF, did you guys do PEDS yet
We're in the
In
process.
front of this.
with Emmett?
Yeah,
Get ready.
yeah.
Get ready.
That's right. Yeah.
He's a great teacher. He's a great teacher. He loves what he does.
Yeah.
Is he retired yet?
No, so he's still 84 going strong.
Crazy, right? Still driving around his little Porsche? Yeah, man, he's legit, old school.
Yeah.
So CF, he probably spoke about this. If not, he probably will. All right, so CF is the most common fatal autosomal recessive disease amongst Caucasians, one in about 2,000 births now. So we do screen for this with prenatal screening now to see if you do hold the gene for CF. All right, CF has a average life expectancy to about 31 years of age. All right, we do not have a cure for CF. It is a lifelong disease, and it is a terminal disease. Typically, your patients are going to be very, very young that are diagnosed with this. So your infants that are diagnosed, your very, very young children. There are some patients that get diagnosed in adolescence or young adulthood because they have this mild atypical form. But the classic type patient is going to be your newborns or your children that are first diagnosed. And it's because of the fact that they get recurrent pulmonary infections. So the recurrent pulmonary infections, they also tend to be very, very thin, underweight. It should be looked into. So you patients that are getting pneumonias 3-4 times a year and are very, very frail. They can't eat. They complain of steatorrhea. They have greasy stools. Secondary to pancreatic insufficiency associated with cystic fibrosis, it should be looked into immediately. And the diagnostic test of choice for this is sweat chloride testing. All right, so you need to know that sweat chloride testing greater than 60. It will be in the slide somewhere. But that is diagnostic. So the issue is that we have abnormalities and mutations in the cystic fibrosis transmembrane conductase regulator. What that simply means is that we have a abnormality in the way that we saturate our secretions with fluid. So they become very, very viscous, very, very thick, and our exocrine properties aren't able to function well. So this is an exocrine abnormality. All right, so if it's exocrine, that means it also affects the pancreas, right? Amylase, lipase, and trypsinogen and trypsin. So therefore, you're not going to digest fats, starches, and proteins. If you can't digest fats, starches, and proteins, what happens? You get malnutrition. So typically, your patient with cystic fibrosis is very, very thin. They're underweight. They can eat a pizza, 4 Big Macs, and a gallon of ice cream and lose weight. Studies show that patients with CF that are a little heavier actually do much better. They do much better because they're holding on to some nutrients. So when we treat patients with CF, we want them a little heavy. It's probably the only time in medicine you're going to hear you want somebody a little heavier. Everybody else, you don't want them to be heavy, right? It's just got too many abnormalities that are associated with it, except for these patients. So when it leads to this thick, viscous secretions in infants when they're developed, one of the pathognomic hallmarks of this is meconium ileus. So babies should pass meconium. Meconium ileus is essentially intestinal obstruction in an infant. They don't pass meconium. It's almost pathognomic for cystic fibrosis. If your infants, your newborns that don't pass meconium, they should be worked up for cystic fibrosis. Now, again, a lot of genetic testing now does take place when you get pregnant. And this is genetically linked. So we already spoke about the exocrine abnormalities that we'll see. You spoke about the intestinal abnormalities. But think about the pulmonary abnormalities that you'll see. So if your secretions are so thick, they're like rubber cement in your lungs, what's going to happen to you? You're going to be able to clear anything?
No.
Stagnant mucus gets infected. So they're just going to pool infection in their lungs and not be able to clear it. Sinuses. What happens when you can't drain your sinuses? Sinus infection. So repeated sinus infections as well. Fertility. Are you going to be able to ovulate properly if you have no secretions? No. Males, high incidence of infertility as well. Does it mean that they will be? Does it mean that they will be infertile and not be able to conceive? Absolutely not. That's why we have CF in the world today, right? So you still have to counsel them, but also let them know that your chances of not being able to get pregnant or have a child are much, much higher. But it can still happen, so counsel them. Let them know this is a genetic disease. If your spouse does become pregnant, there is a chance that they could have CF. So then they have to go for genetic counseling right away. So respiratory wise, kind of makes sense, right? If you have thickened secretions, you're gonna cough, shortness of breath, wheezing, dyspnea, fever, chills. It'll form chronic bronchitis. All right, with or without bronchiectasis because of so much obstruction, recurrent pneumonias. These patients end up with digital clubbing. Your asthmatics and your COPDs typically don't, right? These patients end up with digital clubbing. And it's pretty obvious. So when you see their fingers, it's very obvious that they have clubbing. So it should be thought of. Cyanotic congenital heart disease can also cause this, but think of this in your adolescents or in your adults, when you see digital clubbing, say what's going on. Different types of vasculitis can cause it, different types of malignancy, but also CF can cause it. So again, extrapulmonary involvement, I think that we discussed this. We spoke about sinus disease, and again, I think it makes sense to you. If it doesn't, just let me know. The steatorrhea, fat-soluble vitamins. You're going to be deficient in A, D, E, and K. You don't have the ability to break down and reabsorb fats because of the pancreatic insufficiency. So when we have these patients, we treat them with pancreatic enzymes called creon or pancrease. So every time they eat, they take 1 to 2 tablets every time they eat, and still they have difficulty maintaining weight. So it's just really those tablets are pancreatic enzymes in the oral form, so they take it every time they eat. That second to last slide, again, almost pathognomic. I would know this. They're going to ask you on the boards. They will ask you. So please don't let that go by. So failure to pass meconium or meconium ileus, almost pathognomic, needs the workup. Go ahead.
What about Hirschsprung's?
Hirschsprung's a little bit different. So they will pass firm stools. It's typically not seen in your newborn, but you will see it in patients with chronic constipation in your children. But they will end up passing stool. This is failure to pass meconium. This is your like baby just came out, should be passing meconium, doesn't pass meconium. Sorry about that. Liver disease, so biliary cirrhosis, not secondary to drinking. We spoke about the infertility in men and women and low bone mineral density in adults. And I mean, it kind of makes sense, right? If you can't absorb fat soluble vitamins, you have an increased risk of osteoporosis. So diagnostic approach goes, it's a little cumbersome, the diagnostic approach, but you have to be very in tune to your patient. So if your patient's presenting with multiple pulmonary infections every year and is below weight on the growth chart, it has to set off bells and whistles in your head. Get the sweat chloride testing. Sweat chloride testing greater than 60 is diagnostic, and then you could do DNA genetic testing as well to confirm it. So indications for sweat chloride testing, I'm not sure that you necessarily need to memorize this. Obviously, if they have a sibling that's confirmed with it, parents that have it, then yeah, obviously you're gonna do that. Your older children that experience symptoms, male infertility, chronic respiratory infections, yes, you can obviously look into it. That meconium ileus, 110% should be looked into. And infants with positive newborn screening results. So you do this, there's a newborn screening result for a newborn and you kind of check the boxes. All right. And if they're below weight and symptomatic, they should be screened. And again, sweat chloride greater than 60 is diagnostic. So treatment wise, so your patients are treated, they're not cured. The only way that there's a cure for your patient with CF is lung transplant. That's it. So we treat these patients. We don't cure these patients unless they get a lung. Okay, so we typically maintain them, and this goes for also our end-stage COPDers, our patients that may have interstitial pulmonary disease, pulmonary fibrosis, end-stage pulmonary diseases. We tend to maintain them on antibiotics such as azithromycin, right, to help prevent infection. Your types of bugs that you end up getting as a child, staph and MRSA are your most common. As you grow out of that child into adolescent and adult phase, Pseudomonas is your most common bug. So it's a little bimodal. Younger staph and MRSA, as you get older, Pseudomonas. Obviously, we use a lot of bronchodilators in these patients. We use a lot of medications to help with clearance and to help break up all of these thick secretions. Have you guys ever heard of acetylcysteine? And acetylcysteine, what's it used for?
Tylenol.
Tylenol overdose. How many doses?
I don't know.
Oh, you had me, man. Anybody know how many doses for Tylenol overdose?
Yeah, like how many doses of Tylenol you need to have?
No, how many doses of acetylcysteine for Tylenol overdose?
Too bad. I don't know.
17.
17?
17 doses.
That bad?
One of the most fatal drugs out there is Tylenol.
Mhm.
You could swallow a bottle of Xanax, you're probably gonna live. You swallow a bottle of Tylenol, finished. But so acetylcysteine, and what that'll do is that takes any of your solid secretions and it liquefies it. So I use a ton of it in the hospital. I use a ton of it in the hospital when I have a lot of patients with aspiration and mucus plugging. It works phenomenal, and all of a sudden their cough is just very loose and voluminous. It's great. It's exactly what these patients need. All right, hypertonic saline we commonly also use, and it is just hypertonic saline, 1 to 3% saline. Put it in the nebulizer, let them suck on the nebulizer every 4 to 6 hours. Works very well. DNase-1 also cleaves a lot of that sputum, works very well. Chest physiotherapy. So we order a lot of vests for these patients. We order vests for these patients. We order vests for chronic COPD or interstitial lung disease. And then mechanical vests that rattle their chest. So when you're rattling their chest, it vibrates their chest, so to speak. It breaks up the secretions. It helps with movement. And you got to reinforce to your patients, if you want to get sick, just keep sitting down. You will get sick because if you're sitting down, you're not using your lungs. You got to get up. You got to walk around. You got to get up and do the stairs and exercise as much as you can. Use your lungs as much as possible. That's why we utilize a lot of incentive spirometry in the hospital. They're bedridden patients. What happens when they're bedridden? They get pneumonia quick. Very, very quick because they don't use their lungs. So this is a little guy with his chest physio vest on, with his little nebulizer, his Elmo nebulizer, just sitting there getting nebulized. right? But that chest physio vest, it rattles up that chest, it helps with excretions. Now, the Cystic Fibrosis Foundation is an amazing foundation. If you have patients that are challenged and they cannot afford these treatments, they'll give it to you for free. I mean, these vests could be up towards $10,000. Nope, it'll be at your doorstep like in 2 days. They'll take care of it. All right, so it's a great foundation. Anybody familiar with Boomer Esiason? One football fan in this whole place. Everybody fails except for you. All right, so Boomer Esiason was a football player. He was a quarterback, Cincinnati Bengals. Sound familiar? You guys know who the New York Jets are?
Mhm.
All right, just wondering. So he grew up about 10 minutes from here. All right, and he went to East Islip High School. His son has cystic fibrosis, so he sponsors like all of this stuff. And his son is doing very, very well. He's older now, doing very, very well.
They get a lung transplant.
Say again?
They get a lung transplant.
If they get a lung transplant, it's cured.
Oh,
I'm sorry?
did his son
Not
get?
yet, not yet. Not needed. You only get a transplant when you need it.
But if he doesn't get it, he'll still die.
He'll still die. If he doesn't get a lung. He's gonna die at some point.
So that's
It's a terminal disease. So eventually they end up on a transplant. Treatment wise, so we use a lot of anti-inflammatories, right? So systemic corticosteroids, inhaled steroids. We also use a lot of, do you remember when we discussed antibiotics, the antibiotic lecture? Remember tobramycin we went over? It comes nebulized. It is a direct acting antibiotic for the lungs. It saturates the lungs. It is very, very good for preventing infection. We also use it a lot on our end stage COPDers. So we'll use it like 1 week out of the month. We nebulize them for 1 week out of the month with tobramycin to prevent infection. Works very, very well. But they are highly prone to infection, so be very aggressive if they do present with infection. These people, typically when they have pneumonia, you must admit them and really treat them aggressively. Lung transplant is curative. Any questions with CF? Go ahead. Nothing that has been promising yet. Nothing that is broken the mold. We do have medicines, but nothing that is. The average age is 31. It doesn't mean on your 31st birthday, on June 15th, kiss everybody goodbye. It doesn't mean that. But it does mean that the average age in a cystic fibrosis patient is 31. So that means you have some patients that are 20. You have some patients that are 45. But there has been nothing that's been groundbreaking as of yet. Bless you. Very sad disease. Any questions with that? TB. TB is the #1 cause of death by an infection worldwide. All right, mycobacterium tuberculosis, 3 million. I would say 2 to 3 million. I think 3 million is a little bit of a stretch. I would say 2 to 3 million, 2 more likely. 2 million deaths per year. It's a lot. It's a lot of dead people every single year. And in this country, we tend to have a very good grasp on tuberculosis. Third world nations do not. So we have a lot of testing that goes on. Bless you, we have a lot of screening that goes on. You couldn't get into this school without being screened. You will not be able to go out on rotation without being screened. And even then, some of the hospitals will say, yeah, that's good that you were screened, do it again. So they have a very, very firm grip on it. You apply for a job in a hospital, it doesn't matter if you're pushing a mop, you're getting screened. So in this country, we are a melting pot. We have people that come from all over the world. Europe, South America, Africa, Asia, Middle East, it doesn't matter. But because of that, there is a chance of resistance. So when you have patients that come from all over the world, they carry different strains. So when they come with different strains and they mix with other strains, now you end up with resistant strains. So we tend to treat this extremely aggressively. We don't treat it with one drug, we treat it with 4. And if you have a resistant form, we had 2 more, now you're on 6. So it's not taken lightly. And it's treated very, very aggressively. So who typically gets it? Anybody that typically lives in substandard living, homeless, HIV, malnourished, your patients that are battling malignancy. And again, this is another disease state of the lung that doesn't just stay in the lung. Soft skin, soft tissue, bone, any organs, brain, it can affect anything. But only laryngeal and lung are contagious. Not soft tissue, not in the bone, not of the adrenal gland, it doesn't matter. We actually use tuberculosis, maybe you have, I haven't heard of this. We use active tuberculosis to treat bladder cancer. Have you heard of that? So intravesicular injections of active TB for bladder CA. They'll actually, with a Foley, they'll flush tuberculosis into your bladder. It will destroy cancer. Is it transmittable? No, it's not.
Well, wow.
I don't know. What else should we inject it to?
Any others?
Right now, only bladder. Try it. But so again, so please know, only laryngeal and pulmonary are contagious. Bone, soft tissue, or anything else is not. People freak out over this. Freak out. You look to your left or your right, that person could be PPD positive. You're not going to get TB. It's actually harder to get TB than you think. You have to have major contact with TB, like live with somebody. All right. So that's why it's more common in hospital settings, jails, long-term care facilities, things of that nature, dorms, things like that. That's why you have to be screened before you go to school. So I had a patient in the city, HIV, very low CD4 count, fever, chills, bloody sputum, cough right in my face. Right in my face. Had TB, put on isolation, treated. I never contracted it. Right. So it's actually a little harder than you think. So a lot of people think that if they ride the subways, they're sitting next to somebody that's coughing, they're going to get TB. Not going to happen. It's not going to happen. You ever see that movie Outbreak? Never saw Outbreak? Yeah. The people that are in medicine, you probably never sleep again. But like somebody coughs in a movie theater and you see all the particles go out and the whole movie theater is like sick and dead. That's not what TB is. You know, it was really almost like an Ebola virus type thing. It's not like that. It's not like that. So we changed the terms a little bit. So tuberculosis infection now means latent TB. We use the term latent TB. Tuberculosis disease means active TB. So if you have tuberculosis infection, can you transmit it? No, it's latent. Now, where does latent TB hide? In the lung. But it's latent, it's not in its active form. So we are not immunocompromised. We get exposed to tuberculosis by inhaling the respiratory droplets. We test positive on a PPD, but we're not sick. We're not having weight loss, we're not having fevers, we're not having bloody sputum. We're not sick, and everybody we live with, they're not sick either. Why is it? Because we inhaled those droplets. We have tuberculosis, but our immune system has shut it down. It shuts it right down, but we test positive for it. You cannot transmit latent tuberculosis. Most in this country of people that have active TB is from untreated latent TB. Does that make sense? So when you get sick, maybe you get influenza. We've spoken how badly influenza wipes your immune system out. Maybe all of a sudden then tuberculosis starts ramping up. You undergo chemotherapy. All of a sudden you end up with tuberculosis. All these drugs that you see on TV like Humira, Skyrizi, all these other drugs, what do you have to be checked for before you take them? TB. They flat out tell you on TV, got to make sure you don't have tuberculosis, right? Because it'll immunosuppress you, and then the tuberculosis will activate. So right now, you could be sitting next to somebody that has tuberculosis infection, and you're not sick, and neither are they. But when you tell them, they freak out. They lose it. Not a big deal. This is not a big deal. Go ahead.
With the regular tuberculosis infection, we still have the caseous granuloma.
Are we talking about active TB or latent?
Wait.
No.
No. Okay, so what would a chest X-ray?
You
look
may
like?
have cavitations.
Okay.
You may have a little cavitation in the apice, but chances are you have nothing. No. Did somebody else have a question on you? Primary TB. This is when lymphatically, hematogenously, this spreads throughout your body, and you don't have the immune response to actually protect against it, and you end up getting it. But most of your patients are going to have active TB from activation of latent TB. So again, this is what I was referencing to in the beginning. We have a very good handle on it here, but we are the melting pot. We are a melting pot. So there are resistant forms of tuberculosis that come over. And if you don't think that you're going to see it, you're crazy. If you think that you're going to, practice medicine on the North Shore, maybe you practice in Manhasset, North Shore, Manhasset, ooh, nice area, and you're never going to see any of these diseases like malaria, you're mistaken. You're going to see malaria. You're going to see dengue. You're going to see it's yellow fever. It's here. So don't think because where you practice, you're not going to see it. You will see it. So don't underestimate it. People that have unsuccessfully cured their TB, they're going to need more medications. People that are non-compliant are going to need more medications than the norm. Mortality rates with multi-drug resistant up towards 90%. So signs and symptoms. Your patients are going to present with malaise, fatigue, weight loss, chronic cough, maybe bloody sputum, night sweats. And it's not like, ooh, it's hot in here, open the window. It's like you soak through your clothes 3 times in one night. You had to change your sheets 3 times in one night. So when people tell me that, I think of 2 things. I think of 1, malignancy, and then 2, TB. So when you think of night sweats, it's not like, ooh, it's warm in the room. No, it's you're melting, soaking through your clothing. Exam-wise, typically the exams are normal, and if they're not normal, usually they present as a pneumonia, and your pneumonias can trick you where you say, oh, the patient just has a pneumonia, and they're getting worse, and they're not responding. Think of TB. Personally, my standard of care, my practice is, if you have an upper lobe pneumonia, I run a quantiferon gold dog. It's just my standard of care. It's not what you have to do. It's not the standard of care, but it's something that you should think about. If you have a patient that has an upper lobe pneumonia, is it tuberculosis pneumonia, or is it community acquired, or whatever type of pneumonia? You can't tell by a film. And it's too easy. You're already doing blood work on the patient. It's too easy to just say quantiferon gold. And when it comes back positive, now you got to look into it. Labs. So how do we diagnose it? Well, I just brought up quantiferon gold. Does that diagnose active TB? Does not diagnose active TB. PPDs do not diagnose active TB. They diagnose exposure, latency, but they don't diagnose activity. That's why we need sputum cultures. So get 3 morning sputums. Those are the juiciest, right? In the morning. Get 3 morning sputums, and we're checking for acid-fast bacillus. You could also get that out of pleural washings, pleural cultures, bronchial washings, but you could just get the sputum for acid-fast. If it comes back positive, your patient's got TB, active TB. Latent TB will not produce sputum cultures that are positive with acid-fast bacilli. Active TB will, not latent. Questions with that? Imaging wise, chest X-ray. very, very hard to read. There's a lot of crowding in the apices. So we know that TB tends to like to go up to the apices, not always. It could be basal and pneumonia. It could be biliary pattern, and I'll show you that, but it tends to like the apices. There's a lot of crowding here. Trachea, cervical spine, clavicular heads, sternum, cervical rib. So there's a lot of crowding up there. So it can be a little difficult and a lot of shadowing to make that diagnosis. Hilar and paratracheal lymph node involvement, especially the paratracheal lymph node involvement. Pleural effusions, are we thinking TB right out of the gate? No, not usually. Not usually. Cavitations on chest x-ray, that's when we really start thinking about it. Maybe they're a pneumonia. Maybe they're an upper lobe pneumonia. Think about it. Just run the quantiferon gold test. If that comes back positive, get acid fast testing on them, put them into isolation until it's proven negative. Miliary TB is a diffuse hematogenously spread TB where their chest x-ray has a very distinguished look, and it looks like BB shots all over their lungs. And they have very, very small cavitary lesions throughout both lung fields. So it's disseminated. So this is miliary TB. It looks like somebody took sand and threw it all over their chest x-ray. A millet seed is supposed to be some kind of tiny seed. I've never seen a millet seed, but that's where it comes from. But these are tiny cavitations throughout both lung fields. I just had a miliary TB like 6 months ago. This person's trached, by the way. You see it?
Yeah.
Here's another miliary TB. See how the tiny specks all of it looks like sand thrown across? All very tiny cavitary lesions. What else do you see on this film? It's a great film. What? Constipation? Just gastric air. Anybody see this? It's a cavitated right upper lobe nodule. Can you see it?
Yeah.
Do you see all the cavitations in here? It almost looks like you're looking at the moon, the craters in the moon. So if you were to look at this and just say, oh, I just see miliary seeds, and this could look just like histoplasmosis. But if you look closely, if you start looking, now all of a sudden that right upper lobe pops out. Maybe it doesn't. Does it not? Can anybody not see it? You don't see it. Just tell me you don't see it. Okay. Yeah, now look over here. See how clear this is up in this apice? Look over here. This is not so clear in here. So this outline right here. And then if you look in the center, it looks like almost like you're looking at the moon. See how dark and speckled this is? It's a cavitary lesion. You won't see it on this side. Say again? Well, this is larger than a nodule. So this is pretty big. This is probably by this size, looking at this, I would say that this is about 2.5 by 4 centimeters. So that would constitute a mass. Where do you see it? This? I think this is more rib edge. How this rib is overriding this rib. See the rib coming down here? And this rib is overriding. But good pickup. What was that? You have to come point it out. Right here?
Yeah.
No, hilum. But good pickup. So testing. 2 tests that we could do. We could do PPD testing for screening, which we use purified protein derivative, and you do 0.1 cc's intradermally. If it goes sub-Q and you didn't get the little wheel or the bump, it's not an accurate test. So this is why I don't really like PPDs. One, it's subject to the person giving it if they actually gave it the right way. Because if you don't get the wheel, the test is no good. If it goes sub-Q, you're not going to get the wheel. It's got to be intradermal. And two, it's also very subject to the person reading it. We measure the area of induration. You guys know the difference between induration and erythema, or induration and fluctuance. Do you know that difference? It's super easy. So if you make a fist, the first web space, make a fist, push on that first web space, that tissue, feel how hard that is? That's indurated. Now loosen up your fist. Now push it. That's fluctuance. So if you were cutting into something, you want to cut into fluctuance, never induration. Secondly, we measure that area of induration on the arm when we're measuring a PPD, not the erythema. So a lot of people are like, oh, the redness is 10 millimeters. Yeah, but the induration is like 2 millimeters. So it's a negative PPD. So it's very important. So what I'm trying to say is PPDs are very subject to interpretation, the person interpreting it. Two, they have to come back within 48 to 72 hours. If they come back before 48 hours, too early, come back. If they come back after 72 hours, too late, come back in a week. If you do it sooner than a week, it can give you a lot of false positives. So there's so many variables with PPDs. So a lot of people are like, well, why the hell do we still use them then? They're cheap. They're not a lot of money. So we still use them. So if you were paying cash and you're like, I have to get to Toro College, they're not going to let me in without this stupid, and I don't have insurance. This is the test you want to get. Quantiferon Gold is a lot of money, a lot of money. So you just get this. It's more inconvenient, but it's cheaper. The standard definition of seroconversion, which means the time at which they had it last, which was negative, to now is 2 years. So if you had a negative, what that means is if you had a negative PPD before school started, and now you just finished a whole year, you passed pulmonary, you're all excited, you passed through the third semester, you're going on to your rotations, you got to get that PPD again. Now all of a sudden you're positive. That's seroconversion. You seroconverted in 1 year. Anything greater than 2 years is not a true seroconversion. So seroconversion within 2 years is a true seroconversion, needs to be looked into further. A lot of things can cause false positives. If you were not born in this country, you were likely given BCG. South America, Mexico, Africa, Middle East, South Asia, Southeast Asia, China, where it doesn't matter. You were probably given Russia, you were given BCG, and BCG is the injection. It's the vaccine against tuberculosis, which can cause disseminated TB, osteitis, all this other stuff. Can we get it here? We can, but you got to get it from the CDC. We don't give it here. That can cause a false positive PPD. It will not cause a false positive quantiferon test. So does that mean that we should not do a PPD on our patients that had BCG? And the answer is no. They still can get it. But again, and now it's subject to interpretation. What's better for those patients? Just do quantiferon testing. The thing is that BCG, we think, may last only about 10 years. But what if it lasts 20? What if it lasts 30? What if it lasts only 5? We don't know for sure. So we still can test them, but they're set to a standard, and it goes by age. So let me just skip to this because we're talking about this. Wait, where is it? Is it here? It's got to be here somewhere. BCG, if you're under the age of 35 and you've had BCG, when giving a PPD, greater than 10 millimeters is considered positive. It's in the notes somewhere. You don't have to write this. Don't worry about it. We'll come across it. If you're over the age of 35, then BCG, over the age of 35, if your PPD is greater than 15 millimeters, is considered positive. So under 35, greater than 10 if you've had BCG. Over 35, greater than 15, which is the norm for us, for everybody else. So that's why it's much better just to do quantiferon testing on patients that have had BCG. Only TB exposure will cause quantiferon testing to be positive, not BCG. This table I would definitely know, have to know it. All right, you need to know for the boards, you need to know for the tests. It's very straightforward, simple. So, how do we interpret a PPD test? Again, very subjective. If you're HIV and you've had very close contact with an active contagious person, less than 5 millimeters is considered positive. So that's smaller than the size of an eraser head. And they have a special tool to measure the induration. If you're HIV, if you have had exposure to somebody that is highly contagious, if you're immunosuppressed, any of these patients, it's 5 millimeters or greater. Go ahead.
Any of them?
Any of them. If you are a transplant patient, if you are under the age of 4, if you're a healthcare worker, it's greater than or equal to 10 millimeters. If you're a regular healthy individual, greater than the age of 4, with no risk factors, it's greater than 15 millimeters. So I had a person in the office that had to get, because the hospital will keep tabs of this and they make you redo it every year. So last year she was negative, she's an MA. Last year she was negative. This year she does it and she's like 24 millimeters. She's like blown out. She's hysterical crying. Do you think that's a positive? It's an allergic reaction. So she's freaking out. I'm laughing. I'm like, relax, go downstairs, get a blood test done. Quantiferon's negative. So should she ever have the PPD again? No, she had an allergic reaction. So there's that part of PPDs also. Treatment-wise. So please know this. Please. Treatment-wise, you don't have to know the regimens. And what that means is you don't have to know that we give INH for 4 months and we give PZA for an additional 6 months. And you don't need to know that. Just be able to recognize the drugs. Okay, because there's multiple different regimens for different types of patients. So you don't need to know regimens, just know the drugs that we use. We discussed this during antimicrobials, right? Right? Is everybody familiar with it? So it's INH, rifampin, PZA, and ethambutol. Those are the 4 main. So please know those 4 main. Please always know that you must replace vitamin B6 in anybody that is taking INH. Have to be on B6 while on INH because the biggest side effect is peripheral neuropathy. So please supplement that. Whether you're pregnant, non-pregnant, doesn't matter. INH, B6, they're synergists, they go together. All right, they're like peas and carrots, they go together. And please also know that streptomycin is absolutely contraindicated in pregnancy. They will ask you this. Everything else on there, it's for your reference. Again, this is a regimen, so you're not responsible for this slide. It's all regimen based, except for the last 3 bullets. If your patient is being treated for active TB, and they miss greater than 14 days, if they're 8 months into their regimen, they got to restart over again. If they miss less than 14 days, just tack on those remaining days onto the end of their regimen. Point is, don't miss it. Don't miss therapy. With this, again, if you're treating patients with HIV, they should be treated for a minimum of 9 months. including 3 months of seroconversion negative sputums. Some are treated for 18 months. If resistant, they can be treated for up to 24 months. What should you know about this? Nothing in this. Again, it's all regimen based. It's really too much, to be honest with you. I'm even sorry I put it on here. What you need to know out of this is second bullet, streptomycin, absolutely contraindicated in pregnancy. And it doesn't matter if you're pregnant or not, INH and B6 go together. Doesn't matter if pregnancy or not, male or female, always INH and B6. You must know this slide. And what you need to know from this slide is, this is the treatment for latent tuberculosis. So 3-4 years ago, it was still INH. It was still INH for 9 months. It's no longer INH for 9 months because of side effects and monitoring. You have to monitor their liver enzymes every 4 months, every month. It's rifampin. It's daily rifampin for 4 months. Just warn them, rifampin turns your urine and your sweat and your tears like an orangey red. Tell them not to freak out. It's fine. But it's only a 4-month regimen instead of a 9-month regimen. It's much better tolerated. So I would know the first slide, the first bullet, because that's the guideline. Which changed, like I said, 3-4 years ago, somewhere around there. This is BCG. We were talking about this. I think we spoke a lot about this. You can get it in this country if you work at a TB clinic or infectious disease clinic, and you work with a lot of TB. You can get it. It's got to be ordered by the CDC. Complications: osteitis, osteomyelitis, disseminated TB, but very, very rare. Most people never get vaccinated in this country. We think that, like I said, we think it lasts 10 years, but I still have my hepatitis B immunity from like 25 years ago. So there's no telling how long it's actually going to last. I think we spoke about this slide. The take home from the slide is that you can test people with PPD that have had BCG. Just learn how to and recognize that they had BCG, and 2, learn how to use the scale appropriately. So under age 35, their max is 10 millimeters or greater. Over the age of 35, we allow them to go to 15 millimeters or greater for positive. If you had BCG and I did this test on you, and you came back and you were, say you're 30 years old and you came back at 16 millimeters, personally, I would not treat you. I would make sure, and I would clarify that and reinforce that with a quantiferon test. I'm not looking to put you on medicine for unnecessary reasons. If you do get a positive quantiferon, you should be rechecked with another quantiferon. If you have a positive PPD, you should clarify that with a quantiferon. If you have a positive quantiferon, you should clarify that with a second quantiferon. Go ahead. Say again. That sputum will only check for the active disease, not latent.
If they had a positive PPD but had the BCG vaccine and they got a chest X-ray and it was normal, is that also like they're good?
Yeah, so I don't really like that because yes, in some standards, but the answer is you may not see it on chest X-ray. If you really want to know, just get the quantiferon. The quantiferon is standard. So take home from this, if you have it, we could kill it. That's it. Latent TB, we'll kill it. And the nice thing about latent TB is once we kill it, now you're immune. BCG should still be checked. And relapse is very, very low. It's more commonly seen with non-compliance. Otherwise, they typically do very well. This is Mycobacterium on Lowenstein Jensen medium. This is acid fast staining. So I think I told you guys, on your boards, they may throw out like 1 or 2 histology slides. You'll get something like this. I had sickle cell disease, like stupid easy stuff. So this is not my film, but this is a great film. This shows you some of the multifocal infiltrates in the upper lobes. All right, so in a patient like this, and this is the reason why I do quantiferon testing with anybody that has upper lobe involvement. You may just say, oh yeah, this is multifocal pneumonia in the upper lobes. Let's put you on Zosyn and Vanco and it'll be fine. It's not gonna be fine. So just make sure that they don't have, and it's just very, very easy to just do the blood work. Upper lobe density. What do you see here? It's definitely a harder chest X-ray to read. It's not blatantly obvious like the other ones. Say again. Next to the heart? Next to the heart where? Here? Okay. Yep. Anything else? Here? Pulmonary hilum.
Yeah.
Can you see it? Okay. Anywhere else? Here. 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 A lot going on here. Obviously, much easier, right? Right up below. Go ahead. Here. So right here, if you kind of just, you ever see those pictures where you look at it, it's like a bunch of squiggly lines, and then you look at it a little longer, and all of a sudden it's like a face. You ever see those? That's how you never saw those? That's how you have to look at this. Try to look at it. So look at this long enough, and all of a sudden, if you stare at this long enough, all of a sudden you see this hazy, moth-eaten lesion here. So you see how it's kind of rounded here and then cuts across, and there it's all these cavitations in here. Same thing right here. And you see all these cavitations. So if you look at it long enough, all of a sudden it starts to pop out at you. Are you able to see it?
It's sort of like,
Yeah, but it's very easily missed if you just say, if you throw the X-ray up, oh, it's negative. Oh, it's negative. Oh, it's negative. And you're like, oh, it's not negative. So on the other side, if you look right here, remember, your lung should be black with a little bit of white here and there. But when you have white densities like this, and then you have it right here, and then you have something irregularly formed right here, it starts to pop out of you. But now if you CAT scan this, it shows up much easier. You're welcome. And by the way, paratracheal lymphadenopathy right here. Go ahead.
What's the like linear looking white streak? Is that normal?
This?
In the right lower? Yeah,
This guy?
yeah.
Nope, totally normal. Normal vasculature. Here and here. No, it's fine. Let me see if I can find another one for you. I have another chest symphony. Any questions?
How many questions gonna be on the phone?
I don't know. I gotta make it. When is it?
I have no idea.
How many you want?
Yeah, honestly, that's fine.
100? You'll be in the seat until Christmas.
That's fine. Yeah, we've had 100 questions. I think we've had.
Yeah, but we haven't had three.
Give us a
No, it's just.
or 80.
So it's gonna close.
80 on, you know.
I think 100 may make you angry.
Like a sort of-
Wait, how many questions could you ask?
Say again?
How many questions could you ask?
Well, how many lectures did we actually do? How many?
6.
I
6, I mean,
guess not, but I didn't.
Oh, yeah.
65?
Like seven worse. When I actually thought like.
What?
Right.
Yeah, like
80?
70, 75.
You're gonna have to be prophylaxed for a blood clot. My questions are like this long.
That's okay. It's only gonna help us.
All right, I'll try to do as many as possible.
Yeah.
I feel like I can only make so many, like,
I know.
but I can do that. I'll try to do as much as possible. You all- Any other questions?
Give us some hard ones.
Don't go to get about your kids, like, how do you feel about something?
First of all, don't listen to them. You're all weak. Don't listen to them. Are you not weak? So here's how I would study for my exam. Don't memorize. Read it and understand it. Flip through it, read it, understand it. Blood gases is blood gases, right? You either know it or you don't. So, and those are very, very straightforward questions. But when you're talking about, let's do TB, obviously, I'm gonna give you a clinical scenario on the measurement of somebody's PPD. So you may get somebody that is BCG positive, is 33 years of age, and is now here from, where are they from?
You said South Africa.
South America. They're here from South America. And their PPD is 14 millimeters. What's the treatment of choice?
Or nothing.
I mean, so I was thinking about treatment.
Yes.
What's the treatment of choice?
It is quantiferon. Where is it?
Quantiferon doesn't treat.
So then.
So I would give you like rifampin, PZA, INH, or streptomycin.
Okay.
Rifampin. If I gave you a patient that is got a CD4 count of 100, has been living with a patient with known tuberculosis, and now has cough and fever for 3 weeks with bloody sputum. What is the treatment of choice for this patient? Right. If I have a patient that has recurrent pulmonary infections, chronic coughing, is below weight, what's the diagnostic test of choice? Sweat test. If I have a patient that is 50 years old, non-smoker, presents in the emergency room with shortness of breath, chest pain, fever of 103 times 3 days, dark colored sputum, chest X-ray confirms right lower lobe thick opacity. Vital signs are 90/60, heart rate is 130, SpO2 is 90, and temperature is 102.9. What is the treatment of choice? So what's the treatment for community acquired pneumonia? What is SMH again? I just smacked my head. So, all right, so if I told you augmentin plus azithromycin, by clindamycin, ceftriaxone with azithromycin, with doxycycline and Levaquin,
So.
ceftriaxone and azithromycin. Say again? Which one? No, community acquired pneumonia is dual therapy, right? What else did we talk about? African American male with cough, weight loss over the past 4 months. Elevated calcium level of 11.2. What's the diagnostic test of choice? Biopsy. Done easy enough? So like you can't just memorize. Yeah, I want you to be able to apply the information. Who's the memorizer here? Then you're all gonna do fine. It's the people that memorize, that walk around their kitchen memorizing treatment of choice for community acquired pneumonia, stuff for accidents, and if you're one of those people, get past that. Don't do that. You're wasting your time. Right? So just remember why we use 2 therapies for community acquired pneumonia. You remember the list I gave you, community acquired pneumonia? It's so long. You have to be able to cover both of those, atypical and typical. What other questions you have? Ask me now. No questions?
Did you look at the lab map test?
I didn't get a chance to look at the lab math test, but I heard that the grades were not bad at all.
They definitely support.
They changed like 3 points back like yesterday.
Yeah.
Yeah.
What was like the average?
They don't know it, that must be on. And like, we have to professor that's like on the part.
So did you do better than you thought that you did?
They also helped us out. I don't know how. I think they knocked some questions off.
They probably took,
Then I checked back, or the rate for something else back yesterday, and I checked and I like, remember my scores like went up, not complained, but I was like, they changed.
all right, good, good.
Yeah.
That test should not cause you that much anxiety. That it should. There are much more important tests to cause you anxiety than that.
It was this bad.
What was that? Of course, yeah, of course, but that shouldn't be, that's not a test that should cause you to like jump out of a window. Like. What was it? Multiple press.
Yeah.
That makes it look, that makes it much, that definitely makes it better.
Some of it,
Right.
but then it's just like the nervousness.
That makes it.
Yes.
You're gonna take that medicine and you're gonna find for you like, these are 2 totally different styles. But I don't lecture, I don't teach to. I find that to be almost insulting. Like, to me, that's like, okay, this person's got down and read the notes, they're able to answer and spit out the notes. Where if you wanna do well, more application. So my test more application based, which, it's funny, because at this point in time, you may not appreciate it, but when you get out of this scene, engineer, in your litigation, see what the hell.
What, radio?
Yeah.
It definitely does.
It was great.
Just getting people that say, wow, you have so much information. Well, I always look at it, is you can ask me any question. Or, right.
My brain, not.
Yeah.
Yeah.
You wanna be able to.
We did fine. Yeah, exactly. That's all you need. Oh, not ideal, but.
Yeah. Yeah, they're all gonna be clinically, relevant, and yeah. So always look at the one, read the last
Yeah.
sentence first. It'll teach you Which way is the question heading? Do they want a diagnostic, answer, do they want a treatment question, do they want diagnosis? So it kind of puts you right in that perspective, and then always look at who we're talking. We're talking about, we're talking about somebody that's 80 years old. We're talking about very, very important. All these things are very, very important. And then always be vital.
One thing I'll be.
That's like key.
I know.
So
There's
if I
been times where
tell
I
you
just like
that,
questionnaire.
you know, this person is a smoker,
There's been times where I
And,
just like ran
uh,
for something.
yeah,
I think it was the last one at the
Yeah,
end.
right.
Yeah, I was like, oh, by the way, like I was doing that. I was actually doing that.
spontaneously.
And then I see like go back and.
But look at, they'll say that the person's 6'3",
I don't forget when I.
205 pounds, so the tall, thin male smoker, right? So it's probably not a PE, it's more likely a spontaneous smoker.
Yeah, me too.
So
I forgot that.
take that all into consideration. The answer is in the question.
Everything.
It's like the patients,
No,
It's like the patient's
I
like-
know, because there's something.
the patients tell you what's wrong. You just have to listen to them. Well, the questions tell you what's wrong.
me and Suzanne were going, and I was like, oh, and when I do like.
Just dig a little bit and you.
When they, like the history thing first, she's like, oh, I don't think I have to do it.
You're like, that's a good, that's like you.
The regular thing.
Say again? I will try to do as many as I possibly.
So, and here's her thing first. I would, that's not no thing.
Yeah.
Oh, that's only 2 weeks away.
Yeah.
That's only 2 weeks
And
away.
where did you do
Yeah,
it?
we're in Yeah, it's
Like,
Yeah, you got.
They live in that till like the rest of the semester, so like we have more exam until more summer.
All was the season.
Oh, really?
Oh, really?
I don't think so. All was is easy because he feels bad. I don't feel bad.
Right.
I'm sure science is very different.
We have very different lifestyle.
Like very different.
So see.
We get yelled at, like that.
Yeah.
Well, you also taking this class at like 7 o'clock at night.
Yeah.
I'd be like this too. It's like, are you doing it Zoom or in person?
I hate
Like
it.
next week we have the entire, every
Yeah.
day.
Every day.
So you know, like pulmonary artery hypertension, groupings, stupid asthma.
Yeah.
She missed that whole lecture. She's like, no, we didn't get it.
Everybody looks like a.
Malignancies.
Introduce a little bit.
Yeah.
So did you do like, the goal criteria? PD?
Yeah.
Oh, yeah.
They do all relevant stuff, but I think his test is to.
Is that?
Like,
Like we finished all his. Like,
That's good.
we should love it. I think, no.
So you're gonna do. Just remember, I'm not looking to hurt anybody, I'm just looking to challenge, that's what I agree.
Oh.
I am,
That's something else.
but I am, so like. So, I remember once what it was like in school, is I hated it. Because it just.
I was wondering if
Wanted to do.
It's just.
I
Yeah.
didn't want you to say.